So today I wanted to start by thanking the ARP for the opportunity to share our latest understanding on the role of genetics evaluations in the care of individuals with autism and neurodevelopmental conditions. And I wanted to clarify as part of the title that even though the title is Genetics Care in Adults and Children with Autism and Neurodevelopmental Disabilities, that what we're really talking about are diverse abilities. So as Maddie mentioned, this project is supported by HRSA through a grant that supports the ARP. And what we would like to start is to defining some terms that we're going to use throughout today's webinar, including the term autism spectrum disorders, which, as we know, encompasses a group of neurodevelopmental differences that include differences in social interaction and communication, but also some stereotype patterns of behavior, that it's fairly common. It's diagnosis present in up to 1 in 58 individuals in the US, and that we know that there are some gender biases, and that there are, of course, not only genetic contributions, but environmental ones as well. And then when we look broadly at what is known to date about the genetic contribution to susceptibility to autism spectrum, that there are more than 800 genes, and the list becomes broader and broader every day, that each accounts for a small number of cases. Now, the other term that we wanted to be aware of is developmental delay, broadly defined as age-matched differences in 2 or more categories of developmental milestones that can include language, motor, social, or activities of daily living. And that the diagnosis is usually made before the age of 5, which is usually when a lot of individuals, particularly children, are first identified. And that autism spectrum conditions can overlap within this distinct group of neurological presentations. So in many instances, we'll actually see or observe developmental delay that can then evolve into intellectual disability in some cases associated with autism spectrum phenotypes as well. And that we can call a combined diagnosis, and may represent, in some cases, more severe instances of autism, and that other symptoms and other medical conditions can be associated with them. So when we're discussing the challenges for genetic diseases in general, we have some instances or some information available from large studies that have looked at rare genetic conditions as part of consortia, where we get a sense of the journey to finding a proper genetic evaluation, where 25% of patients end up waiting up to between 5 and 30 years for a diagnosis. 40% receive an initial incorrect diagnosis, and about 25% of them end up traveling very large distances to identify a potential specialist that could then reach a conclusive diagnosis. And in 50% of cases, they receive genetic counseling, but 25% of them were never informed of the genetics at all. So we call this a diagnostic journey or an odyssey, where there's a long period between the symptom onset and the diagnosis. And we know that in cases where we look at admissions to hospitals in children that have significant medical concerns, that there's a genetic component or a genetic contribution to those clinical symptoms in about 71% of them. And that there's a significant associated costs associated with those admissions, particularly when there isn't a diagnosis achieved in a timely manner. So what is it that we really know about the genetic contributions to neurodevelopmental conditions, including autism? And sometimes studying something, a clinical presentation as common as autism, provides insight into more rare genetic presentations. And we know that there is some evidence from twins and familial studies that there's a higher concordance or higher likelihood that they both will have autism when they're monozygotic, when their genetic material is identically shared, than in dizygotic twins, where there are differences among siblings with most of the genetic material. So that, just to begin with, provides a heritability or a likelihood that some of these genetic findings will contribute to the manifestation of symptoms to a high degree. Now, we know, however, that autism comes in multiple instances. We have cases in which the clinical phenotype is associated primarily with other symptoms. that affects multiple organs versus the type of autism that presents isolated without any other major clinical concerns. And when we discuss the more complex forms of autism, some term syndromic, not one entity is likely the cause. It probably represents many different causes, and many patients present with similar symptoms, but their genetic diagnosis can also be very different. So what do we include as part of a genetic evaluation for autism? So first comes the clinical diagnosis, and that's actually administered or evaluated by psychiatrists, psychologists, or neurologists, or behavioral specialists like neurodevelopmental specialists in the pediatrics realm, both in adults as well, that then perform a clinical evaluation and use instruments to identify whether there is a potential risk or manifestation of those symptoms. And then typically what we suggest is that there will be a component as part of that person's evaluations by a geneticist or a genetic counselor to identify any other coexisting concerns, whether they're medical or not, or more neurological. And then of course, the presence or absence or other physical findings, whether there are congenital concerns, or whether there are other differences in external features in the body that can give us clues as to whether there's a higher contribution of a very penetrant or single gene genetic cause. So when we're making that initial assessment, we're trying to find out, is this autism that's occurring by itself, or is it more syndromic or associated with other neurological and organ systems? And the intent of pursuing the testing, which kind of follows the initial evaluation with a geneticist or a genetic counselor, is to help guide, if there is a diagnosis identified, the medical surveillance that may or may not be required once that's achieved, pursue opportunities for family counseling, both for assessing whether other family members are at risk for themselves or their children, provides family support and advocacy, because sometimes a genetic diagnosis provides a community where you can find access to understanding the intricacies of how to deal with day-to-day access to care and challenges. And of course, facilitate understanding prognosis and identifying potential physical concerns that may manifest over time, with potentially having some personalized treatments available in a subset of them. So the idea is to make an impact on the lives of children with rare genetic conditions, and to better understand the clinical course of these conditions by reaching out to community physicians and practices and families to educate them about the utility of this approach, to provide genetic counseling to address the uncertainty of what caused it and whether it will happen again, which is part of the diagnostic journey. And many times more than one affected child is born before a diagnosis is made, which may have placed some bear on future family planning. And of course, to be able to anticipate potential medical complications like seizures and develop a personalized treatment plan, if available and appropriate, based on those future comorbidities or coexisting medical problems. So as part of the genetic evaluation, we take a very careful family history to again identify whether there are affected siblings or other family members, the prenatal history to ensure that there haven't been any exposures during prenatal development or any differences that might have contributed to the symptoms that you're observing in the clinic, the developmental history, because that can be telling about whether there's a pattern of loss of milestones or slow attainment of specific developmental milestones. And then of course, a physical exam where we're looking for external features that might be sufficiently unique or that stand out, that might suggest that there might be sort of a pattern that could suggest a monogenic or single genetic ideology. And of course, that is coupled with genetic diagnostic testing, and some of that you will hear about today. So in general, the features that we feel are suggestive of a genetic syndrome include the presence of one or more major structural abnormalities, where there's a difference in the development of an organ that is sufficiently significant that it affects its function. 3 or more minor malformations, and those are differences that might be cosmetic and that might be fairly atypical, but that in and of themselves don't affect the function of that particular body part. But that when you start looking at patterns of how they are identified together in one individual, they may be suggestive of a genetic association. Of course, changes in how your body grows, like failure to thrive, changes in the shape of the face and the head, or additional neurological concerns like developmental delay or intellectual disability, findings in the skin, teeth, hair, bones, external genitalia, an immune system that can also give us clues, as well as changes in behavior and speech. So what do we know? We know that when you look at genetic information, which as you can see here is packaged in what we call chromosomes, that about 10 to 20% of autism individuals are due to known medical conditions that involve some kind of chromosomal imbalance, whether it's a structural problem with the chromosome where a piece of the chromosome is either missing or duplicated, or there might be sort of a single genetic change or single letter change in one of many genes currently known to be associated with predisposition. And of course, that there are some environmental exposures that can increase that likelihood in association with genetic findings or independent of them. Now, the way that we actually approach this testing in the clinical setting is to pursue chromosomal microarray testing as one of the first tier tests that is offered to individuals. And in that case, what it essentially does is it's count the numbers of copies of genes that you were born with. We all have about 21,000 genes, and each gene comes in 2 copies, one from mom and one from dad. It's a little bit different in boys because in boys there's only 1 X chromosome, in girls there's 2, but essentially that's the general approach. And the idea is that if you have a tool that can actually monitor each address or each gene and its location in the whole genetic material, can you then tell if there's a missing copy of a gene or an extra copy of a gene or neighborhoods of adjacent genes? And that's essentially what this does is with the use of a chip. This is the earlier version where you could actually see that there was a loss of genetic material when you look at the normal ratio of 1 or actually having 2 copies of a gene. Now, the tools that we use have changed over time, and now we have much more higher resolution, or our ability to find with more degree of fidelity which genes and which portions of those genes are missing by using microarray tools that are reliant on what are called polymorphisms. And these are variants or letter changes present in the population that may make us different, but that don't necessarily are associated with symptoms. And you can use those to then identify whether the copy that you got of the gene from mom versus dad is there or not. And what it does also is also gives us incidental findings, like for example, realizing that there is some coefficient of inbreeding or some relatedness in terms of the family members when an individual is tested, or the degree of consanguinity. There are also possibilities where within these regions, there could be the possibility of what we call a recessive condition, where by having 2 copies of the same gene from one parent, you could also have a genetic predisposition, or by having the same genetic change in both copies may actually predispose to both copies not working at all. So what exactly does the microarray check? So we call them copy number variations. And that, for example, means that if you have the chromosomes in mom and the chromosomes in dad, and there's a process by which you're making sperm or eggs in order to pass down that chromosomal material, that there can be an instance in which a portion of that chromosome is missing. And when you pass that chromosome down to the next generation, then you can have developed symptoms within the spectrum. And I'll give you an example of one of these early situations or instances where we had 2 patients in our practice, one who was diagnosed with autism at the age of 5, but then when she presented in the clinic, presented with significant neuropsychiatric changes that occurred at age 10 that included bipolar disorder and psychotic features. Then we also had another individual who was diagnosed at the age of 7 with autism, but then by the age of 15 developed significant psychosis that has required multiple admissions to the inpatient psychiatric service. And it turns out that when the microarray testing was performed, that there was a region of chromosome 3 that was missing in one of the 2 copies of the chromosome in both individuals. And it turns out that that region includes genes that are now known to be important in the communication between neurons and facilitating the signals that promote that interaction between neurons to remain very stable. And what ends up happening is that this genetic condition, which we call 3q29 microdeletion syndrome, initially associated with autism, because of that pattern of co-association, became now in larger studies that looked at schizophrenia or individuals with psychosis, both in children and in adults. This microdeletion is actually now recognized as a common associated genetic predisposition for schizophrenia. So as you can see, in individuals that initially presented with autism, where the symptoms, or what we call the phenotype, evolved over time into a schizophrenia picture, we were able to identify a genetic predisposition that is now recognized even in individuals who only have schizophrenia, but no prior history of autism. Now, there are some limitations to this testing. It may not detect low levels of mosaicism, meaning changes in chromosomes that are a very small amount in the blood system that may not be identified. It doesn't detect changes in genes that are not associated with a net gain or loss, where, for example, the gene gets longer or shorter. It will not detect that. And there are instances of genetic conditions where the gene length is important in causing symptoms. It will not detect if there are chromosomes that have sort of stuck to each other and in the process affected a single gene where they reattached, because if there's no net gain or loss of genetic material, you will not be able to detect it. And we know that there's a significant frequency of these events that can lead to symptoms. And of course, it will not detect single letter changes in its gene or in the instructions of its gene, because it's designed to just look at addresses and not really at reading the instructions within its gene. Now, we know that the other testing that we typically perform as part of first-year testing is Fragile X syndrome testing. And we know that that's due to, again, an expansion in the size of the letters in the gene FMR1. And we know that when that occurs, you can have a specific behavioral profile with some physical features that are associated with it. There's actually carrier screening, meaning this expansion typically happens when the genetic change is passed down from the parents to the next generation. And you can actually identify a pre-expansion that can then lead to the significant increase in the number of repeats that leads to symptoms. And in fact, now many parents during the pregnancy are offered carrier screening for Fragile X syndrome as part of their pregnancy planning. Now, chromosomal microarray and Fragile X testing was the main paradigm for initial testing offered to individuals with neurodevelopmental concerns, including autism. But this paradigm shifted in 2009 when there were a couple of papers that first described the use of a new technology called whole exome sequencing to define the genetic cause for rare genetic conditions that had escaped or eluded an answer for many decades. And the reason was that this test could actually then, in one sample, essentially do a spell check on all 21,000 genes and then identify, by using parents as reference, where the changes were that were rare enough that could lead to this clinical presentation. And of course, by looking at patients that had very similar symptoms, that increased your likelihood that you would be able to find an answer. And that's how they did it. So why is exome sequencing useful? Well, it turns out that fast forward to a decade later, and many studies have gone on to demonstrate that there's a high contribution of what are called de novo genetic variants to the predisposition of neurodevelopmental concerns. And in this case, what we're looking at is if you have, again, the genetic the genes or the genetic material in both parents, as the genetic material is being passed down, there can be a spelling change in one of those many 20,000 genes, 21,000 genes that then gets passed down to the next generation and then causes neurodevelopmental symptoms. So this initially research tool transitioned to the clinical realm around 2012, and that ended up being what we now currently known as clinical exome sequencing, which is a clinically available test through many commercial and academic laboratories. And it's intended to identify about sequence variants or changes in about 95% of all the genes that make protein. It sequences also mitochondrial DNA, which is a genetic material that's present in all of our cells that regulates how we produce energy, and that is separate or distinct from the DNA that we all carry in our cells in the nuclei. It can detect, just like microarray does in many instances, the loss of one or more genes in one or two copies of the chromosome. It costs thousands of dollars. It has a 30-day turnaround time, and it requires consenting prior to sending. And that typically is performed by a genetic counselor for reasons that I'm going to discuss in a minute. So as part of this counseling, what we want to obtain is a comprehensive family history as well as past medical records to ensure that we have as much information as possible about what the clinical presentation of the patient to make sense of what the genetic variants that we identify. There's a consent process, and it's intended to make families aware that, and particularly the participant that's getting, or the individual that's getting the testing, of a number of risks that include identifying misattributed paternity, consanguinity, and incidental findings, which means changes in genes that are not necessarily causing symptoms now, but for which there are opportunities for interventions and prevention later on in life. We take time explaining the mode of inheritance so that it's clear what are all the potential outcomes of the testing, what the recurrence risk could be once the results are back, your reproductive options and whether this will impact them if that is the context in which the testing is being performed. And then, of course, addressing psychosocial issues that may actually impact the process of testing, which include not only repercussions in terms of family impact, but also financial impact in terms of insurability and other aspects. And of course, we provide community and professional resources that are meant to provide consent and counseling at a level that's adequate to each individual family's education level. So clinical exome sequencing is ideal in settings where there's a typical history of years without a diagnosis, of a lot of clinically unexpected findings, and no one can put the pieces together. And many times the reason that all of these unrelated and unexpected clinical symptoms being related is because there's a gene that is known to predispose to all of them, or genetic change that's predisposing to all of them. So of course, we're looking at primarily conditions in which the symptoms don't really tell you which gene is the cause. And there are many so-called genetically heterogeneous, meaning symptoms can be caused by a different number of genes. And some of them include seizures. Seizures can be caused by genetic changes in many different types of genes. Autism is another one of them, but of course there are also neurodegenerative diseases as well as diseases of the eye, where you can have the same symptom, which is loss of cells in the eye for vision, but that could be due to a number of different genetic causes. So in those situations, doing a test that includes all those genetic causes in one test is much more effective, both cost and time effective, in terms of trying to finding an answer. Of course, when you have an atypical presentation of established genetic syndromes, you will never suspect that. So for example, you might have situations in which you have mostly behavioral concerns and no other sort of specific neurodevelopmental diagnosis, and a lot of both psychometrists and developmental pediatricians and geneticists, we all struggle with defining what the symptoms are. But sometimes that is due to sort of, we can call either milder or atypical presentation of a well-established genetic condition. And that is one of the questions that I'll pose at the end, that we still don't understand. Why is it that one individual with changes in one gene can present so differently, or with a more limited number of symptoms, as opposed to others who develop a pretty much laundry list of concerns? So when we discuss exome sequencing, and specifically how effective has it been in identifying etiologies of genetic single gene predispositions to autism, we know already, again, from a vast literature, that there's an increased chance of a dominant de novo mutation in autism and schizophrenia. We know that by dominant, we mean that by having one copy of the two that we inherit of this gene have a change is sufficient to give you symptoms. And de novo, we mean that they happen typically spontaneously, either in the germline or after conception. That exome sequences has identified de novo genetic changes in about 15% of autism cases. That is sometimes associated with advanced paternal age. And we've known from genetic literature for a long time that in certain scenarios, the older the father is, the higher the likelihood that we've seen of some of these genetic de novo dominant mutations occurring. And of course, genes identified are associated in addition to with autism, with seizures, with ADHD, with schizophrenia and psychiatric disease. And that spectrum of clinical manifestation is part of the question that we still don't understand well. So the approach to clinical genetic testing, to summarize, essentially starts with the clinical diagnosis of a neurodevelopmental concern. Then you decide if it's primarily autism as idiopathic or isolated, or is it autism with other symptoms? You pursue chromosomal microarray and Fragile X testing. If you have a diagnosis, you stop, and that happens about a quarter of the time. But sometimes what happens is that you don't get a diagnosis after the first year of testing, so then you move on to the next tier, which could include clinical exome sequencing as a second tier, or even as a first-year test. And I'll give you examples where recent guidelines suggest that. And of course, if you identify genetic change, which can happen about 30% of the time, then you'll have a potential genetic predisposition identified.
Thank you, Dr. Martinez. So we are now going to transition into our panel discussion. And over the next 20 minutes or so, we're going to cover 4 topics. So now we're going to be joined by Zach Williams and Felicia Williams. And would you two please briefly introduce and describe yourselves, starting with Zach?
Sure. Hi, I'm Zach Williams. I'm a 6th-year MD PhD candidate at Vanderbilt University School of Medicine. And I am also an autistic self-advocate. And so I'll be providing a personal experience as an autistic person, as well as an autism researcher for this panel. And physically, I am a white Hispanic young adult, and I have black hair. And my background is a white background with the AirP logo in the top right corner.
Great, thank you, Zach. And Felicia, please.
Yes, my name is Felicia Williams, and I am, I guess, a middle-aged Black woman with long hair. I'm wearing a coral dress and a colorful scarf. My background is white with the AirP logo. I am a connection and resource specialist with the Autism Society of North Carolina. I've also done a lot of self-advocate work as a community health worker. And I am also a mother of a child with autism. He is 13 years old. And I am here representing the parents. Thank you.
Great, thank you both. So our first topic is to discuss and talk about parent versus provider versus personal perspectives on genetic testing. And so if Julian, if you wouldn't mind leading us off on sort of your views on these different perspectives, and then we'll sort of go through the group, please.
I mean, I think as a provider, I've essentially discussed or set the background for why we feel as providers of genetic testing and genetic evaluations that the opportunity to pursue them is helpful for individuals, right? Whether they're children or adults, autistic individuals. Now, what I have experienced as a provider is when you interact with families and autistic individuals, that perspectives can be very different, right? And one of the ones that we find a lot is concerns about how that information is stewarded, right? What are the implications of that information on insurability for certain individuals, depending on what those findings look like? And then, of course, when it comes to making a very personal decision about whether this is important in the family dynamic, right? One of them is this idea of if it's a genetic change that's inherited from one parent, what is the impact of that on the family structure? About questions of, was this passed down by you, and this is why so-and-so is like this or that. And then questions about perspective on pregnancy and motherhood, right? And realizing what could have happened, what could I have done, could this have been different, right? And sometimes the genetics evaluation provides perspective as to the fact that there was nothing that happened in the pregnancy that could have been any different, and how that sometimes the diagnosis can put some perspective on that uncertainty, which a lot of parents carry about Could it have been different? Could it have been something that I ate? Could it have been some falling during the pregnancy? Could it have been the evil eye? All these different things that we hear all the time, and lifting some of that concern away.
And before moving on to Zach, could I just follow up, Julian? In your experience, roughly what proportion of families, when offered genetic testing, are interested versus resistant to it?
Yeah, I mean, I think there's two corollaries to that question, right? Because first is how many families who are offered by their referring physician, right, to come actually come, and it's actually a very small number. So I hear from my primary care colleagues that even though they offer the referral, very few actually follow through, right? It's usually about 10%. And that's something that I think it's a gap that we want to address. What are the concerns at that point that are not being communicated, that are leading those families to perhaps not pursue it? And it may be perceptions about futility, about, is this really going to help? Why am I doing this? Why is this important, right? So I think that might be an important gap to fill. And then that's different from the ones that actually do make it to the genetics appointment. And then we offer it, and then they say, well, let me think about it. And all of that, I think, has to do with family dynamics, number one, right? Are parents on the same page about testing, or is the individual ready to pursue testing based on the risks associated with it through the counseling that we do pre-testing? But also, I think it has to do with costs, right? Because a lot of the times insurance don't cover it, or there's a high copay or co-insurance that you have to fulfill. And then the third one is the question that I always get, which is, why are we going to do this? And many times the argument that we make is not good enough, right? And I think that it's perfectly reasonable to say no and move away and step away and say, Dr. Martinez, I'll wait until we have more opportunities for treatments or something that's more meaningful to whatever is important to that family, right? Because that will be different to different families. Some families are information seeking, they want to know, and they want to have the opportunity to take advantage of what we have to offer. But for many families, that is not the case, and that's perfectly fine for us.
Thank you very much. Zach, what's your perspective on this topic?
Sure. And I think, just as Dr. Martinez was saying, I think that there's sort of a very different group of perspectives among the personal perspectives. So, I mean, I have actually had my own genome sequenced, not clinically, but as part of participating in the Simons Foundation Spark study. So it was a research study, and they did a whole exome for free. Now, I guess as full disclosure, I got no like pathologic findings back. Apparently the yield in Spark for participants that they've sent things back on is about like 8%. And so I'm part of the 90-some% who got, nothing of interest back. But that's also fine, I suppose, because I at least got some information about my genetics, and it was clinically interesting to me as a scientist. But anyway, to think about that, one thing to notice for the autistic community is there's a bit of distrust in the entirety of the research enterprise, and genetics in particular has been quite a hot topic lately. In fact, there was a recent study of autism genetics in the UK called Spectrum 10K that was a particularly like hot button issue within the greater autism community, and sort of made it out into even like the lay media about this, which was a study of about 10,000 autistic people in the United Kingdom, and the goal was to basically get genetic samples and associate them with all sorts of health conditions and different things. But basically, there were all sorts of issues with the way that the study was described, both to the participants and then in the grant to the funders, and how those things were disconnected. And people felt like the researchers weren't being honest, or they weren't necessarily putting in the right protections for the genetic data because they were hoping to bank them and allow people to reuse them. But like what they may have been reused for could have been malicious, or things that the autistic community didn't want them to be used for, but we weren't sure that the right protections were in place, et cetera, et cetera. Anyway, so all of this to say is there are many, many different issues that lead, the average autistic adult to be somewhat mistrustful of your the autism research infrastructure, and especially when things come to genetics. Now, I think that families of autistic individuals, especially those who are, newly diagnosed and have a child who has significant developmental difficulties and are seeking, more services, may be more amenable to a more medical approach and information seeking. I think if you have, again, a newly overwhelmed parent who has a diagnosis of child and is willing to get that coming in, then they're probably very happy to seek diagnosis. But especially for like later diagnosed autistic adults, I think very few of them go in and seek diagnostic testing. Me getting this through Spark, would have been the only reason I would have ever done it. I don't feel like I mean, likely a low yield anyway, but had I, gone to my psychiatrist, I would not have paid even under insurance to go and get a chromosomal microarray and Fragile X or whatever they're recommending for me these days. And so, right, I think that the yield, especially in adults, is also something that's not really evidence-based. All of the recommendations are at the time of first diagnosis, which is really looking at pediatric samples. And so other more nuanced scientific issues may play into this too, even though that may not really be what your average person is thinking when they walk into a genetics clinic. But again, a lot of different perspectives and a lot of different issues, and happy to talk about this more as we move through the panel.
Great, thank you, Zach. And so Felicia, as a parent, I'm very interested on your thoughts on this topic.
Yeah, well, first, I totally can relate to what Zach is saying. From a parent perspective, you are concerned about transparency, how that information will be used, and is it really beneficial, or is it going to create more anxiety and fear? So that's definitely something that, as a parent coming from a parent's perspective, I would be concerned about that for my child. I did want to say, from a parent to the medical side, it makes me question, how do you determine who is given the opportunity? How is it offered? Like, is it offered to just everyone, or is it offered to families who already have a child with autism? How do you determine who is offered the genetic testing? And then, are the providers that are doing this, are they serving a diverse community? I think that is important because I know you guys said 10% actually do it, and I know there's a cost barrier, but I think it's important to note that as a parent, I would like to know, no matter what area I'm in, I have the same opportunity to get this information if I was interested in that. So from a parent's perspective, that would be something I would think about, but also just the fear. For me, what comes up is it's nice to know, because then it will affirm, I guess, some of the concerns that you have. But then the flip side of that is, okay, will this negatively impact my child? And will this help with us accessing services? Because it's so hard right now. The medical system has one qualification criteria, the school system has another. How does the genetic component falls into that, and how will that be utilized? So it just opens up a whole nother door to how will this information be received by the community. So yeah.
Those are great perspectives, and it's a really nice segue into our next topic, which is, should every family with an autistic child or adult be offered genetic testing? And we'll start with you again, Dr. Martinez, please.
So I think to address Felicia's comments, which were right on target, what we use as genetic providers as a criterion for offering testing is twofold. One is the autistic individual experiencing other co-associated physical findings, right, or clinical concerns, right, that are impacting their health, right? And I think that's a very important criterion, because based on the research that we have, that is the population that will most likely benefit from testing, right? If you're an autistic individual who's otherwise healthy and has no other major other clinical concerns or physical differences, the likelihood that the genetic testing, at least as we use it today and how it's intended to be used, will be very low yield, as Zach explained earlier. So I think it's important that, as Zach said, participation in research studies that are trying to understand why is there such a discrepancy, right? And differences, and what it may be the genetic reasons behind that is useful. And I think that's why participation in studies that are trying to understand that is going to be important. But I think it creates a difference in referral and who should be evaluated, right? Now, we don't put the burden on deciding that to the families, right? What we want to do is educate primary care providers to recognize who are the individuals that would benefit most, and then refer them, right? So that they can then access to the genetic testing as soon as possible. Now, having said that, genetics is very humbling, because most of the time, even though we think we have all the answers, we always get proven wrong. And I've been proven wrong many times, where I've had individuals where I felt the likelihood of genetic testing was going to be extremely low, and parents are very big advocates for pursuing it. So we pursue it, and we actually find a genetic predisposition, simply because genetic predisposition is so variable in many cases that you could have someone who carries it, but otherwise is completely healthy. And I think understanding that variability is where those other genetic testing, the other genetic research studies are going to give us insights into why is it that individuals that have changes in the same gene present so differently, and in some cases with no health concerns at all. So stay tuned, because I think as more participation in these questions and these studies occurs, we'll get more information about why that happens. And then I just wanted to follow that with Felicia's concern about the anxiety, about the fact that even if you offer genetic testing and you do get a diagnosis, then you transition from the diagnostic odyssey to the post-diagnosis odyssey, which I call it the post-diagnosis PTSD. And that is the combination of the anxiety, or the what ifs, or the hypervigilance about surveillance, making sure, is this going to happen or not, right? About the what is going to coming next, what's new, what can I know, right? What can I do that is not yet to be found to help? And I think that creates its own sort of different state, right? Initially, it's the what happened, but then the after is, now that I know what happens, what can we do about it? And that comes with its own burdens as well. Absolutely.
Zach, what are your thoughts on whether everyone should be offered genetic testing who has an autism diagnosis?
Sure. And it's a really interesting question, and I actually think that there are different ways to go with this. To some extent, my answer really is no. If the genetic testing means should everyone get like a whole exome or a whole genome sequencing, yes, you could probably find a lot more and a lot more people by doing this, but right now, I think that if as a medical system, we wouldn't really be able to shoulder the costs or make the interventions that we have based on those findings worthwhile. But for the big syndromes that we have, based on copy number variants, because those things have been around longer and studied more, I think that based on current recommendations to do like a chromosomal microarray and Fragile X testing, based on just that and the costs of those things, we could probably justify at least all children who are newly diagnosed getting offered a test, and then perhaps even tiering that to say, like, if there are additional dysmorphologies or other physical findings that would increase the likelihood to have that be more strongly recommended. It would be, I do appreciate the opportunity to have that offered universally, because I think it does cut access barriers to put additional guidelines on that. That being said, I do still think currently, you're not going to get more than 20% yield with these tools if we screen everyone. And so there may or may not be justification cost wise to do that. And if we stratify, we might be losing some kids, but it could be better overall. So I don't know. Again, it's a question for health economists, but I think that there are certainly reasons to go, both ways.
Great, thanks, Zach. Do you have anything else to add to this topic, Felicia?
Yeah, I would just say I think that for someone who is questioning, they have not received an evaluation, they're noticing some of the symptoms. It would be nice if there was a way that they can inquire about it. As far as it being offered to everyone, I don't think just right off the cuff, no. I think there, of course, like you guys are saying, there should be some concern or some qualifications, the primary care, or, a family already has a child with autism, something of that sort, just because of the anxiety it produces. And then I think for those who do it, there should be some form of robust counseling and transparency of all of these risks and concerns, how this will impact a family, how this will impact an individual. So yes.
Great, thank you, Felicia. We have two more topics. The next one is to discuss what the ethical concerns associated with genetic data and what can be done to address them. And that could refer to clinical genetic testing, or as Zach was talking about, research genetic data and testing. So Dr. Martinez, do you want to start us off?
Yeah, I mean, I think this is a very broad topic, so we'll just sort of touch very superficially the main concerns. So I think on the clinical side, the concern is always the fact that the research is moving faster than the conversation about whether the things that we can do should be done or translated into clinical care or clinical diagnostics. And I think one of the emerging one is for individuals that might not have sort of a single gene or gene loss associated predisposition, but more of the common genetic changes that kind of come together to perhaps increase that risk, meaning multiple changes in many different genes that in combination then increase the likelihood of having health concerns. That if there is actually a mechanism or a tool that allows you to create a score or some kind of guidance as to the likelihood that you have of developing those symptoms over time, when that is used and how, right? And I think there are questions about whether that information, which is actually emerging as a very powerful and potential way of using it as an adjunct to sort of lifestyle changes and understanding our health in general, is how can we use those common genetic changes to understand our risk of diabetes, our risk of different health concerns, right? But the question is, when you're making decisions that are important, when is that relevant or not? And is it relevant for all differences, right? So do you do it for psychiatric differences? Do you do it for issues of identity that have to do with gender health and sort of who we are? Do we do it with in the prenatal setting as your family planning? Do you then say, if I can predict whether my next generation is going to have X, Y, or Z, do I use that information to make decisions about what my next family member is going to look like, right? So I think all of those are big questions that are being addressed on the clinical side as to whether the fact that we have this technology means that we should take advantage of it in all settings at all times, right? And I leave to Zach the more research related questions, which are also very important as well.
Zach, you're up.
Yeah, and I think really when it comes to the autism community's concerns, and one of the major things that's at the front of everyone's minds is what is going to happen with people's research data. Because one thing that a lot of autistic people are really genuinely worried about is the thought that people can use large banks of genetic data to do things like come up with prenatal screening for autism, and then use that to essentially, give prenatal genetic counseling to expectant mothers and say your baby has this likelihood of being autistic if you want to terminate the pregnancy. Now, I mean, that's obviously very controversial and probably, quite unlikely based on how well we're able to predict autism with polygenic scores and things like that. But theoretically, if you are able to, have better predictive models with, your whole genome sequencing and more data, this is at least something that these large banks of data could contribute to feasibly. And so people in the community are worried about the opportunity for some bad actor to at least apply for this data or these data if there are not appropriate protections in place. And so this is essentially what started this whole backlash from the community against this major study, was that there wasn't enough in place to say that this couldn't happen. The research team, clearly came out and said, like, no, we are against prenatal testing for autism. We are against eugenics. We do not want this. But it was apparent that they still were interested in coming up with polygenic scores for other things in relation to autism, because this is part of how like large scale genomics research works, and like understanding the phenotypes of autistic people still comes up with them getting a lot of autistic people's genomes together, which still takes their data and makes it available. And so then how that is safeguarded and the ethical protections of those data, and how to prevent those data from being misused for nefarious purposes or purposes that are antithetical to what the autistic community stands for, becomes a really, really, prime ethical discussion for everyone in the community, researchers and autistic people alike. And those are the things that we're still grappling with. The Spectrum 10-day study, after a 6-month hiatus and redesign with many external consultations with the autistic community, a new community board. I mean, they've done quite a lot to try and bring this back and incorporate new partners, hired an external consulting firm. I mean, I hope they're doing this the right way. I don't know. I haven't actually seen much of how things have gone since this, but with all the press on them, I believe that they've definitely got a lot of time, money, and effort put into doing this right. So I'm really hopeful that they can show people that genetics research can be done ethically and with the proper amount of community involvement and attention paid to these really tough issues, because I think it's important that we still study these topics, but in a way that the community can get behind and be able to work with.
Great, thank you. And then Felicia, as a parent, do you have ethical concerns around genetic testing?
Absolutely. I would second everything that Zach just said, but just from a parent's perspective, that is exactly what we worry about too. How is this information going to be used, and how is it going to be protected, and how will it impact processes in the future? So that is definitely a concern. The other concern that I have as a parent is just how the community is educated about genetic testing, because the simplest things are created and then people are misled, they're misinformed, they get in an uproar, or they have this expectation. And as families, especially our families, like we're out there real researching, we're trying to find the answers, and there are a lot of bad answers. And so I think one concern would be making sure, if this is something we're doing, that we provide adequate educational opportunities and materials and information to our families, so that they have the right information and they are informed properly so they can make quality decisions about it.
Great, thank you so much. And our final topic is about access to genetic testing and how we can improve accessibility. Dr. Martinez?
So I'll just briefly summarize what Felicia said, right? So what we're trying to do is establish conversations with primary care stakeholders, who are the ones that are actually having perhaps the first point of contact for any individual who's seeking healthcare. I think underserved populations are experiencing a different healthcare system than most others. And I think that's the main concern that all of us have, that disparity that's intrinsic to the healthcare system is further causing barriers to access. So I think that's one that we want to improve through improvements in primary care providers' education and literacy about genetic testing, and communicating that to families, also doing it directly to individuals, autistic or their families, to actually be more empowered, to know more about genetic testing and have access to those resources for self-knowledge and information-seeking individuals. And then, of course, we want to sort of implement processes that reduce the time to wait to see a practitioner, right? To facilitate testing. One of the initiatives is to try to make testing as cheap and as affordable as possible so that it can be more broadly available to as many people as possible. So the technology side is moving in that direction. And then working with payers to make sure that that is also supported as well with clinical evidence of its utility, right? So I think all those processes in parallel are going to sort of move the needle forward on improving access.
Great, thank you. Zach.
And yeah, well, I think that most of those like healthcare level interventions are going to be the primary way that we work to improve access to genetic testing. I think another thing to think about is in attitudes toward the field of genetics and genomics in general. So it's no secret that the autistic community is very wary of like genetics as a field, just because of the whole Spectrum 10K thing. And I feel like medical genetics, despite being fairly separate from that type of genetics research, has still really suffered a crisis of reputation as a guilt by association. And so one thing that could really be done to help restore the faith of the autistic community, which certainly interfaces with the parents of autistic kid community, would be to have researchers improve their ties with community members and show more participatory research, and that genetics research can be done in a nice and ethically sound way. And so in doing that, the overall attitudes toward genetic testing would probably improve, which would then perhaps make the amount of people offered genetic testing who then go and see a genetics provider go up.
Great, thank you, Zach. And Felicia, your thoughts about how we can improve access to genetic testing?
Yes, I agree with everyone here. I'll just second what they've said. But one thing that came to mind for me is making sure that the information is available to all cultural communities. I know right now there's just such a barrier to how people get information. And so what happens is those families who are well connected, they are well connected. And then those families who are not, they never know. And so, maybe just not through the primary care, but go to where the people are to make them aware, and maybe have someone that looks like them so that they're more trusting, and they're able to relate culturally to them. That will definitely help with education, and it will definitely help with access, people willing to be open to it, changing their attitudes about it. So I think keeping that piece in mind, it would be very helpful, on top of the things that were shared.
Great, thank you. So I want to thank all of our panel members for participating in this ARP-LEN video today. This concludes our video. If you want to connect with any of our speakers from today, please contact us by the email addresses you see here. And we invite you also to follow the progress of the ARP network on our social handles that are listed here. And thank you again to our panel members, and thank you to all of you for joining us today for our video.
Thank you.